All right. Quick question. How many of you want to work for free? Anybody? Nobody put their hands up. I live by some adages and principles in life. Number one, biology always wins. After that, economics always wins. So if you think about it, veins don't kill anybody, but all of a sudden, vein practices are booming everywhere, and what's happening is that. So, is that the very first slide? Oh, I guess we'll go to that one. Okay. So the first question that you must know is, no matter what technique you use, as a doctor, you make the same amount of money. We'll do the math and show you that. And basically, we run a business. How many of you shop at Amazon? Everybody. Costco? Everybody. Google? Everybody. Why? They add value. Medicine's the only business where we keep trying to raise the cost. Look at the phone in your hand, in your pocket, the iPhone. The price stays the same. Everything else doubles. Power doubles. Capabilities double. Blah, blah, blah. We want better, faster, cheaper, except in medicine. And the game that's played is we do more of something because it's paid. The insurance company says, oh, I can't give this money. They want to keep the money. And then this kind of becomes a seesaw and just about everything else. So as docs, we are technicians. We get a fee for doing what we do. And they've always managed this. So when we look at the math, now one rule to remember, some practical stuff. Just because a code exists doesn't mean you get paid. Now, one of the things that has happened with vein practice is one around every corner. More and more doctors are doing this, qualified or not. And there are many specialties who say, no, I want a better life. I want to retire early. I want to make a lot of money. And then they escape from that. There are ER docs doing this. There are primary care docs doing this. There are family medicine docs doing this. Dermatologists, surgeons, and then they franchise this. And if this was Amazon running this, how would they do it? We wouldn't be running our vein practices the way we do. So who pays for this ultimately? Insurance. Insurance is money that's pulled together to manage risk. If you have a cancer, they'll pay $2 million if they have to for the case. But if everybody started getting sclerotherapy done, there won't be enough money for the bigger stuff. So and they do this because they want to make money. So when you look at that, what do? They cut reimbursement. They restrict services. This is not covered, that's not covered. They come up with the term medical necessity. And we'll talk about this. They'll deny the claims even if after you get approval. Then they start auditing. If you overpay them, you have only 6 months to get it back. They overpay you, they have 3 years to get it back. You dance with the gorilla, you got to go where the gorilla goes, right? And reimbursements are falling faster. Now, if you were making chips, like all the chip companies, my God, their price never went up. They just do it better, faster, cheaper every year. They design for value. We design so we make more money. And who drives this industry? So this game's being played, but it will come into the mainstream at some point. So one of the things is coverage is kind of independent of evidence, like compression. We know compression never works, but 90 days, because most people forget by then, some don't care, insurance plan change. Every insurance company is different. Every plan is different. Every region is different. Remember I told you first biology wins, and then economics wins. So money plays a reason here. So who pays you? Either the patient pays himself, self-pay. How many of you would pay $3,500 for an RF ablation on your leg? No hand went up. For a venous seal, for a Varithena? None of you would. But we expect patients to pay it. But self-pay is one. For whatever reason, when they see value, they'll buy it. Then you could do this in a hospital outpatient. That's one fee schedule. Ambulatory surgery center, another fee schedule. In your physician office, global fee schedule. And then finally, if you do it as in an ASC or in a hospital, you can bill separately and get paid. Now, if the carrier, most common Medicare, Medicaid pays nothing. It's supposed to be an aid program. But now they've combined these into advantage programs. And basically, again, it's this. They will control who gets what where. They want to keep their money first. Don't blame them for it. And then kind of ration this out a little bit. Commercial plans, they it'll vary by carrier, by company, then it'll vary by state, but then also by plan, HMO, PPO, etc. And finally, now there's capitation coming up with bundling. Soon, vein treatment along with wound care will all be one. So let's give you some specific codes, and then I can give you some comments as well. So, for example, right now, an RF ablation you get $1,305, which is kind of an average, and the patient has a 20% copay. If they don't have a secondary plan, that's $260 off, so you got roughly $1,100 or $1,050. Your fiber costs you $400, you got to pay for your tech, for your nurse, your pro fee, everything in there. You'll end up making $100 and some bucks if this was a business selling anything else. If you look at the second procedure, so you do 2 veins. If you use 2 fibers, you've already lost money. RF ablation, average $1,631. Actually, this is for Chicago region. $1,631 is what you get, but the RF fiber costs a little more. So if you do 500 per device, you're left at 1,100 left, and then depends on what your costs are set up. If you have an ultrasound tech, a nurse, anesthesia, all this, then you lose money. If you manage this well, you got to keep the quality better, then you will make some money on it. Now, non-tumescent, non-thermal, most private health insurance companies are not approving this. United Healthcare is famous for it. Now, it's really funny. I won't mention the name, but a company that makes a product, their product is not covered by United Healthcare. And United Healthcare employees hate United Healthcare. So I have patients of mine who have United Healthcare, they work for United, and they're not getting approved. You don't get paid for 9, 12 months, et cetera. But the CEO of United made $67 million last year, one guy. And all the other, executives, et cetera. So it's a money game. But now look at Clarivane, $1,613, similar to RF. The device costs $600. Now, some people have billed for this as an embolization code because they were using the glue. CMS has gone after them. Some have, I think there have been criminal charges. I don't know the exact details, but it was considered fraud. A lot of people have paid a lot of money back. Then you have VenaSeal. They pay $2,162, and then obviously the cost is $900 per kit. In the end, what's left for you depends on how you manage it, and you got roughly the same amount of money no matter what you're doing. So and then Medicare for even the non-tumescent covers Varithena, but it's only GSV and an accessory branch. If you access a tributary and put Varithena in, it's not covered. And you can get yourself into trouble. So it all depends on how you do it. And it's a free country, do whatever you want until you get caught. Then there's an entire industry to persecute you, prosecute you, and make an example out of you, blah, blah, blah. So it's good to know. It's like speeding. There's speed limits written there. You can drive at 100 miles an hour. Nobody catches you. It's like a tree falling in the forest. Nobody heard it. Who heard it? Who knows? You're fine. You get caught. Now you're going to pay fines. You're going to lose your license. You get blah, 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 blah. So it's the same here. Just because nobody's watching in the room doesn't mean Medicare, there's a profile. So there's a site called CodeMap. If you go there, you subscribe to it, you put in the code, it tells you who are the top billers and collectors that Medicare is paying for your region, et cetera, et cetera. So this, and all companies do look at this. So Varithena, $1,624. That's $1,692 is what we get in the Chicagoland area. Now, because it's a canister, and they say 15 cc's, up to 15 cc's per person. There's about 75 to 90 cc's. You can squeeze a little more out of it, but that's what the IFU says. If you do less, you use more, you could get more. So it ranges from about 400 to 1,500. But again, once you decrease your cost, and if you do fancy setups, fancy trays, I've seen people do this in an OR. Like, how do they make, nobody seems to care, but that's what that is. So you'll have to stay ahead of the game in this. You have to know your objective. So I truly believe that no human being does anything unless it enhances a value in them. And what do we want? We want to make a living, but we also have a sense of doing the right thing. Some want to do charity, but all because you may feel good about it. So with insurance companies, you will have to fight this. We have a full team that does pre-authorization, all the paperwork. They deny. I've actually consulted for analytics companies, and they get rewarded for the most amount of denials. They have profiles on who is doing how much. If you have a very clean claim and all your claims are very clean, you will get audited. Or they're very dirty because you're not in the standard bell curve. Then they do the math and say it costs $20,000 to recover, and the fraud is worth $100,000, they'll come after you. If they're going to spend 20 and recover 20, they won't touch you. They say, I forget it. So all this is looked at, but to have a successful practice, So there's a reason why they call it cash flow, like blood flow. If there's no money going through your system, you're going to shut down. So in that, you have to stay on top of it, and it's really about managing this very well in line with the patient's expectations. So I'll leave you with this. 2018, the reimbursements are what we showed you, but what's going to happen is you're going to see further squeezing of this all the way down. If you don't look at your patient's insurance carriers at the time of the start, and you make a commitment to take care of them, you have already exposed yourself medical legally, because you are now the treating physician. In a court of law, it doesn't matter if something bad happened to them. So you have to keep that in mind. So a couple of points here. If you have a code, doesn't mean you're getting paid. Check your guidelines. Number two, first is they're eligible. Second is that you get pre-approval, but it still doesn't guarantee payment. And third is you get predetermination. You tell them, this is the code I'm using, this is what I'm doing, and they give you approval and they give you a number. Now, because they're the gorilla, they can still deny you coverage, and then you appeal it, etc. Thank you. With that, I'll leave it and we'll move on to our next talk.